Good afternoon, everyone.
Hi, Dr. Horn here.
Dr. V here.
So welcome to our MD Stewardship webinar. We're going to talk about common infections and appropriate antibiotic use. This is our approach. Usually we give one topic at a time, but I think this is good because sometimes like this, we'll want to cover several things, just kind of the bullet points, just kind of the main things that we think about when approaching some of these infections. And so, this isn't meant to be comprehensive. It's meant to be kind of a review of these topics. So if you have any questions, please just type it in the chat or unmute yourself and ask any questions that you have. And we'd be happy to answer any of your questions. So we're going to go through several topics today. One of them is going to be bacterial meningitis. And we'll cover a little bit on viral meningitis and other types of meningitis, but I think bacterial meningitis is especially important because it's one of the emergencies where you want to make sure they're on antibiotics very quickly. And you don't want to wait until you know what it is. You want to make sure that the number one thing is time to antibiotics when you're thinking about how they do and outcomes. And so this is where we get our information from. This is Infectious Disease Society of America. And here are the classical triad: fever, neck stiffness, and altered mental status. So fever and a headache. Someone comes in with fever and a headache, you're thinking meningitis and getting them antibiotics quickly.
Yeah, I think we haven't talked about meningitis for a while, so it was a good time to just return and just remember, especially with the summertime coming too. There's a lot of viruses in the community as well. So it's just really important to kind of make sure if there's fevers, neck stiffness, change your mental status to think about meningitis, encephalitis. And this is kind of, we call it the classic triad. Especially also some patients present with nausea, vomiting, hard seeing, photophobia. So just keep that in back of our mind, like what kind of meningitis, encephalitis can we be dealing with, and what kind of labs do we need to get in these patients. So on our next slide.
So if you have a suspicion for bacterial meningitis, this is kind of a flow sheet or an algorithm. So what things do you do in what order, right? So bacterial meningitis says yes. Then the question is going to be, do they need a CT scan of the head or not before you do a lumbar puncture? And there are a couple of things here. So if they're immunocompromised, if they have a history of CNS disease, new seizures, papilledema, altered consciousness, focal neurological deficits, so any kind of neurologic finding that's positive, or delay in the performance of the lumbar puncture, then it'll influence whether you won't need a CT or not. So if they have any of these things, it's worrisome for increased pressure, so increased intracranial pressure, and then you'd want to get a CT scan before doing the LP, because if there's increased intracranial pressure, then you don't want them to herniate. And so if they herniate, that would be very bad. So for any of these things, if they have them, you get a CT scan. If not, you don't need a CT scan. So that's kind of the fork right here.
Yeah. And when Dr. Horn is saying increase intracranial pressure, all your ventricles, the CSF fluid, it just like builds up and builds up. So it creates so much pressure. So if you kind of go like put a little release valve, it just it'll herniate your brain, bottom of your brain, tonsillar herniation, and you could immediately pass away. So it's really important to make sure you get a good history and physical. And nothing is stopping us, like we'll talk about it, from giving antibiotic, instead of waiting for CT too.
So if they have these things, you can get blood cultures. Oh, thank you. You can get blood cultures, and then you give steroids and their antibiotics, and we'll talk about what antibiotics in a minute. And then you do a CT scan, and if the CT scan is okay to do an LP, then you do the LP. So here in this one, if you're going to do a CT scan, you want to give antibiotics before doing the CT scan, because one of the issues is that sometimes if a CT scan is done, it will, and people wait for the CT to give antibiotics. There are some studies that show they don't get antibiotics for hours, and then they have worse outcomes. And people will think, oh, the ER is not that busy. I'll get a CT scan. It'll happen really quickly. I'll talk to the radiologist, and then, a car accident happens or something, and the ER gets really busy. And then they go, oh no, what happened to that meningitis patient? And things can get really busy, and forget about the patient, basically.
Yeah, I always say like giving antibiotics is so much more important. Just like for septic shock, you need antibiotics. Every hour you may wait for septic shock, you have higher mortality, 10%. Meningitis, pretty similar. So if you're really worried about meningitis, ideally, not delaying antimicrobial therapy is really important.
So, and people are taught, oh, you can't give antibiotics until the LP is done. Until the LP is done. And when they delay antibiotics for the LP, if you're going to do a CT scan, it's too much of a delay. And so on this side, you give antibiotics, then you do a CT, then you do the LP. And if they don't have any of these things, you don't need to get a CT scan. So you can do blood cultures and lumbar puncture, then give the steroids and the antibiotics, and then go from there, essentially. So do the CSF findings look like bacterial meningitis? You look at the Gram stain, and then if it does, you continue the steroids and targeted antimicrobial therapy. So if you have lancet-shaped Diplococci, then you'd say, oh, that looks like strep pneumo. And then you would target it to strep pneumo. And if not, then you would continue your empirical antibiotics.
Just be also careful. Some of the things that I've learned is also initial CSF Gram stain. It depends on the expertise of the person who's Gram staining it in the lab. So sometimes a microbiologist might be new who's doing the Gram stains. So like it's important. So if you still want to keep it a little broader for bacterial meningitis, keep it broad until you have culture back.
Oh, I totally agree with that. Yeah. And the Gram stains don't always see something. So if the Gram stain doesn't see anything, I wouldn't stop the antibiotics. And it's totally okay to continue your broad antibiotics until you have a definitive identification of the organism. So any questions on this?
Feel free to message unmute and discuss with us too. So when it comes to meningitis, we always think about what is the most common bacteria, right, for bacterial meningitis? And it's always streptococcal pneumoniae. Strep pneumo is one of the biggest common pathogens. But if you're a baby less than 1 month of age, usually it's group B strep agalactae, and then gram-negative bacteria, which is through, when the baby's coming through the mom's vaginal canal, it picks up the vaginal flora. And of course, listeria is something to think about in pregnant women and in babies, which is why we add ampicillin. And then if you're the age between 1 year to over the age of 50, just like looking at this graph table, strep pneumo is always important. In the middle of the age group, you get also meningococcal meningitis, so keep in mind. And then as you get older again, over the age of 50, listeria comes back again. So this is what some of the reasons for the antimicrobials we start initially, and we'll talk a little bit in a minute. But so think about strep pneumo being a big player, immunocompromised, less than 1, greater than 50, listeria being a player. So just some stuff to remember.
And if you look at this list, strep pneumo, like you said, is the most important thing that you always want to make sure you cover for. Well, in adults, but people will say, well, why are we giving vancomycin if we're giving a 3rd-generation cephalosporin that should cover strep pneumoniae really well? And the vancomycin isn't for Staph aureus. So if you look at this, there isn't any MRSA here. And so oftentimes one of the frequent things we get, people will say, do I need to cover for MRSA with vancomycin? And the vancomycin is there, but it's not for Staph aureus. So, but it is important to give, you're basically double covering the strep pneumo, in case it's resistant to the cephalosporin.
Yeah, so we're noticing more and more strep pneumo is becoming resistant to ceftriaxone for the meningitis breakpoint. So that's why we are adding vancomycin, because vancomycin is still 100% for strep pneumo. So we do both. It's a really good point that you pointed out, because I always get asked to, is it for MRSA?
Yes, they'll say, oh, MRSA coverage. And it's
So
like, not so much MRSA, but it's for coverage.
yes,
Yeah.
you're double covering strep pneumo for meningitis with vanco and ceftriaxone. And this is also really important. Some of our facilities, we are, neurosurgery patients are there. You have patients with trauma to your head, CSF shunts we see a lot. So it changes a little bit. Meningitis versus when you have things that go into your brain, you have trauma, then what do we need to cover? And you all see a difference here is that now they say third generation cephalosporin. And the reason behind it is you're trying to cover for also Pseudomonas.
The fourth generation.
Oh, sorry, fourth generation. Sorry.
It went from third to fourth.
Third, yeah. So you're trying to cover for Pseudomonas. So thank you. So making sure you are expanding your coverage for Pseudomonas as well.
And here you do see Staph aureus. So if someone comes in from trauma, like a car accident, or if they fell into a ditch and they're going to have multiple things, that's when you see other things like Pseudomonas and Staph aureus. Now, if they come in with like meningitis-like symptoms, but they didn't have penetrating trauma, they didn't have a neurosurgery or shunt or anything, you wouldn't be including some of these organisms. But the organisms, you could have different things after you've had a procedure, like a neurosurgical procedure or a skull fracture or something like that. So that's when you hear the vancomycin would be for MRSA, especially if they were in the hospital for a neurosurgical procedure, then developed a meningitis. You would be thinking, could this be MRSA? Could this be Pseudomonas? Yeah.
And post neurosurgery, pretty similar coverage. And also, we see a lot of patients with shunts, and shunts not only get MRSA, MSSA, but they also get a lot of skin flora like Staph epi, coagulative Staph. So I'm kind of keeping that in mind. Also, I see a lot of Propionibacterium acne. So, that's another bacteria. So that's why it's really important to make sure, like, depending on what is causing the issue in the brain, making sure we have the right type of antimicrobials. I don't want to illustrate this. It's really important when we do a lumbar puncture, getting some of these other extra tests, because even before your culture comes back or your PCR comes back, there are some like clues. And some of the most important things to do is when you do a lumbar puncture to get the pressure of the CSF. A lot of times people don't do that. It's called opening pressure. And it's really important to get that because it helps. If it's really high, then you need to know, like, do I need to repeat tapping to make sure I keep the pressure down?
And with interventional radiology, we actually have to specifically ask them for the opening pressure.
Yeah. So it's really important to ask for opening pressure. It's really high in like fungal type of infection. Cryptococcus causes really high opening pressure. So just keep an eye on the opening pressure. It's really important to also look at the CSF and kind of look, how does it look like? Is it clear? Kind of gives you a clue. Does it look like purulence? White cells in the CSF. Anything more than, I would say in my mind, more than like 8, I'm kind of worried about. So if you see here, less than 5 is normal. So more than that, you need to start thinking about what is causing that, right? But depending on the different types of infection, it could be hundreds or it could be thousands in your brain, in the CSF.
Yeah, and so if it's less than 5, if it's less than 5, then you can say there's no meningitis. You can say no inflammatory cells, no extra inflammatory cells, not meningitis, and then you can stop right there and say no meningitis. So when they show this, they'll show you the number of cells, and then they'll show a percentage of each of the different types of cells that they find. But if it's 100% lymph, but there are only 4 cells, you don't have to worry about that. You can say there's no meningitis there, and that's okay. So, and that's a question we get kind of frequently. They'll say, oh, it's 100% lymph. You know, it's mainly, I think, when we get from our learners and things, but it's really important because it's easy to look at it and think it's the actual number and not, you know, it's sometimes people say, oh, there are 80 lymphs, and it's actually 80% of
one cell.
well, yeah, right, yeah.
Yeah, I think it's important. And, you know, if you really have high suspicion and they're acting like meningitis, you could wait for the cultures to come back or PCR to come back, you know, next 24 to 48 hours. Usually, if nothing grows in the first 48 hours, you're pretty in the clear. But a lot of times, if you have other reasons, you have pneumonia and some reason you have mental status and you did an LP and they're like 2 cells, it's probably not meningitis. So clinical suspicion.
And then here's another way of looking at it that, you know, it tries to simplify it a bit, which I always like things that are simplified. So it'll have opening pressure here. And so it's normal is going to be, this says about 180, but it's 18 centimeters or 20, 18 to 20 is going to be.
So anywhere between 8 to 15 millimoles per mercury is okay. But if it starts going more than that, it's elevated.
Yeah, and it can be elevated. It's, you know, when it's high, you think, could this be bacterial? Could this be fungal? You know, viral is usually normal. It's usually not so high. And then cell count, you know, if you're looking at PMNs are usually predominant, or if lymphocytes are predominant, you're thinking viral lymphocytes. It could also be TB or fungal. And then protein is going to be high, but it's not always elevated with viral so much. And then glucose is going to be way down with bacterial, because I think those bacterial cells are using the glucose, but viral, you know, it's usually normal with viral meningitis.
Yeah, I think of it in a way that bacteria in your CSF, they love the glucose, and also fungus, they're just eating it up.
Yeah.
But also bacteria and fungal and TB, you have high pressure and high protein because they're just multiplying. So like there are a ton of them just growing. So they're taking up the space. So antibiotics, kind of a quick summary. What should we give when you're worried about meningitis, right? Vancomycin, ceftriaxone, ampicillin, like we talked about, immunocompromised babies, pregnant women, age greater than 50. This is to cover listeria, the ampicillin. If there's any concerns for HSV or you're not sure, add acyclovir until your PCR results come back from your CSF. Usually the PCR results, if you have in-house, it comes back pretty fast. Send out, you know, may take a little bit, but if there is any concern, this is when there's also important to get history, asking the family member, do they get cold sores? Do they have, you know, but if you don't know, they look really sick and you get an imaging and there's like inflammation in their brain and the temporal lobes, for example, you should add acyclovir until you know things. So for me, go-to is vanco, ceftriaxone, ampicillin, plus or minus acyclovir, depending on my concern. And just like what Dr. Horn just went through, if you have trauma or shunts, thinking about Pseudomonas and thinking about anaerobic coverage if there's contamination with soil and things like that. And yeah, go ahead.
Let's see, CSF studies. So as far as the lab goes, the cell count, gram stain, the bacterial culture of the CSF and the blood. AFB, this is so stain and culture. So if they're very immunosuppressed, getting AFB stain and culture of the CSF is a good idea. Fungal staining and culture is a good idea. Also, especially if they're immunosuppressed, but it's fine to do it anytime. Protein, glucose, and then concern for fungal or other infections. Opening pressure is especially important in fungal meningitis, and that may be, you know, especially important in transplant patients or immunosuppressed patients or untreated HIV patients. And then if it's really high, they can remove some of the fluid, which will decrease the pressure a bit. You wouldn't decrease it so much to go to normal because it might be too much of a change at one time. But if they take off some fluid and then look at the closing pressure, if they're going to have a repeat LP, you know, in a day or two, you can look at the opening pressure and compare it to the closing pressure and see is it rising or is it coming down, and kind of get an understanding of what's happening there if they're on the proper antibiotics.
And also, just thinking other exposures, summertime, lots of mosquitoes. So thinking about Lyme disease, sorry, not, I went to say West Nile disease. I meant to say West Nile, or like tick exposure, Lyme, malaria, depending on somebody came back from like India or, you know, travel, fungal infection if they're immunosuppressed. They went swimming in the fresh water, or like they put tap water to rinse their nose, and you're thinking about Naegleria. So like, you know, when there are special circumstances, you kind of have to think about special other labs that you need to order in the CSF. Really think about these different scenarios as well. And then I'm not sure if all of you have access to CSF meningitis encephalitis PCR panel, which is really awesome. It, you know, once you tap, the CSF fluid is probed by all these PCR targets, and it could give you an answer immediately. So sometimes I'll get like a LP, and I know the patient has HSV1 meningitis in like an hour.
Yeah.
And it's amazing.
Yeah, and then you can just narrow right down to acyclovir and have a plan right there and give the patient feedback of what they have. And I'm glad you mentioned West Nile, because West Nile has been pretty big in the last few years. Yeah, last year I saw so many young people with West Nile. And it can be devastating.
Yeah, and they were having stroke-like symptoms too. So please keep in mind West Nile in the summertime.
And for West Nile, you'd want to send antibodies, IgG, IgM, from the CSF or from the blood.
Both. I do both. Yeah.
And that's important also because it's not on the CSF meningitis PCR panel. So you'd have to get antibodies, and you'd have to remember to do that. And it's really important, especially if your cultures remain without growth, to say, oh, am I forgetting something? Am I sure I got everything? Or you know, is it summertime? Could this be West Nile? So it's always, and that's always, I think, a send out. I think we send it out too, but it may take a little while, but there's no specific antibiotics for it or no treatment. It's all supportive.
Yes.
But that would be helpful, because then you can know that they don't require antibiotics. And
keep in mind, young people, meningitis, encephalitis, stroke-like symptoms. West Nile happens a lot now in the summertime.
And then a little bit on brain abscess. So if you're considering, you know, what does this patient have? There essentially, with all infections, there are kind of two ways it spreads. It's either local spread, like here, if it's from mastoiditis, they could have it spread from the sinuses. You know, if they've had recurrent sinusitis, they could have an ear infection and it spreads locally, or it could spread hematogenously. And it's a little bit different, because if it's going to spread locally like this from the sinuses or from the ear infection or from trauma, then you're thinking multiple organisms, where usually if it's hematogenious spread, it's usually just one organism, but you want to cover it really well until you know what they have. But here's a picture of examples of some different abscesses, you know, of different sizes and everything. Here's septic embolus, examples from endocarditis. So if they have left-sided endocarditis and that it breaks off, the parts of the vegetation break off, it can go to the brain and start growing there as well. So it can be multiple things. Here are some imaging pictures of it, CT scan here.
Yeah. What I want to highlight in the CT is like the picture A that you're showing. CT is not the best if you're worried about brain stuff, especially CT without contrast. Only thing it's looking for is bleed. It can't really tell you if there's infection. So if you're really worried about infection, CT with contrast is okay. MRI is really good. So this picture B is MRI. You could see a really nice circumferential lesion. And then different weighted MRI, you could see the edema around it, cavitation around it. So it's really important to be able to get an MRI if you can, or CT with contrast is okay. But CT without contrast that we regularly do in the ER because they're ruling out stroke and bleed is not helpful for brain infections.
Yeah, and if you see something like this, the question's going to be, is this from an infection, or is this, could this be cancer? Could this be something else going on? And if you're not sure, then the question's going to be, how do you identify what it is? Because I wouldn't want to treat for an abscess for a while and then find out they have a cancer there. So antibiotics, surgery, do you want to give steroids? Now, if you think it's an abscess, ceftriaxone plus metronidazole is usually what is discussed, or adding vancomycin if you're worried about Staph aureus, which, you know, if you're not sure, I think adding vancomycin would probably be a good idea. But if you're not sure, if they're doing okay, so if they show up in the ER and they're looking okay, they're not in sepsis or septic shock, if it's possible to wait, you know, until the next day, if it's possible to get a culture of it, a biopsy of it to see if it is a cancer, is it an infection? And about half of the patients don't have a fever. So, you know, you may not be able to tell from their symptoms whether it's an infection or not, but I would talk with neurosurgery or talk about getting them transferred for a procedure to be able to identify what it is before deciding on antibiotics for a couple of weeks and then saying, oh, you know, it's actually a cancer. We've been giving antibiotics for suspected abscess.
So we just finished that topic.
That was a good long topic there. But we do want to emphasize Staph aureus bacteremia also, because Staph aureus bacteremia is one of the most common things that we get questions about. So I think it's good to run through this a little bit also.
Yeah, you know, one of the most common bacteremias, I would say, is Staph aureus bacteremia. And its fatality can be up to 25%. So high risk for patients, outcomes, bad outcomes. And, you know, one of the biggest thing about Staph aureus is it creates biofilm, sticky material everywhere in your heart, in your back, in your artificial joints, prosthetic materials. So it becomes really challenging for us to treat. So some summary, anytime that we see Staph aureus bacteremia, right? MRSA or MSSA. So if it's methicillin susceptible Staph aureus or methicillin resistant Staph aureus, we have to do the right steps because otherwise you could have recurrence or lots of complications. So one of the most important thing is make sure we pick an antibiotic that treats the bacteria. Screen with endoechocardiograph, because if you have blood culture positive with Staph aureus, even if it's one of two sets, the chances of it landing on your heart valve is 25 to 33%, extremely high. So this is why we always recommend getting a echocardiogram. You could start with a transthoracic, but if you cannot get a good picture or if there's high risk, at least then you have to get a trans esophageal. Also, you know, Dr. Horn and I, when we see patients with Staph aureus bacteremia, we do a really good exam because it lands on joints like shoulders, hips, knees, especially on your spinal area, right? Epidural discitis. So it's really important to do a good exam if there's any pain, especially in your epidural space, your spinal area. Getting an imaging is important. Also, you have to then figure out the duration, and ID doctors or antimicrobial stewardship team is important. It has shown that having somebody who's expert in infectious disease actually helps patients' outcomes with Staph aureus bacteremia. So it's really important to make sure that you have that. Again, remember, even if it's one of two cultures, we get said this a lot, is a contamination. You always have to treat it as it's real if it's MRSA or MSSA in the blood, even if it's one of two.
And I would like to say that Staph aureus, ID doctors treat it very aggressively compared to other organisms. And actually right now we have a Staph lugdunensis, and that's a coag negative staph, but it's one that I would treat just the same. And we have a Staph lugdunensis, one of two in the blood, and we got an echo and we got repeat blood cultures, and we're going to treat it aggressively, just like Staph aureus. So that's one to know. That's a coag negative staph, but would treat it just as aggressively as Staph aureus. And here, I'm not sure we're going to have time to go through this whole algorithm, but I think this is a great thing to look at.
Yeah, it's exactly what we just talked about. It's a flow chart. We'll give you the references as well. You know, if you have Staph aureus, Bacteremia, picking Benko, Cefazolin, depending on MSSA or MRSA, here they say start broadly because we don't know. But I think you could, you know, then you could narrow it down, making sure you repeat blood culture after 48 hours. You don't need to repeat blood culture in once you know, like sometimes I see people start getting blood culture in like 12 hours later. You could wait 48 hours, echocardiogram, imaging if you need, if you're worried about spinal or, you know, joint. Source control is really important. Let's say you have a big abscess, making sure it's cleaned out, ID consultation, optimizing your antibiotic depending on your susceptibility. If it's MSSA, use cefazolin. If it's MRSA, use vancomycin or Dapto. So using the appropriate antibiotic for the organism. And then, you know, you don't find any other complication. It's just bacteremia. They don't have any complications at all. No joint infection, no osteomyelitis. You could just do 2 weeks of IV therapy. But if there is concern for osteomyelitis or endocarditis, you end up doing about 6 weeks of therapy. If you're in between, your blood cultures keep persistently positive, but there's no endocarditis, no joint infection, no osteomyelitis, you land in the middle for about 4 weeks of treatment. So it's so it all depends. If you get Staph aureus bacteremia, no complication, 2 weeks. Persistent bacteremia, 4 weeks, endocarditis, septic joint, osteomyelitis, epidural abscess, 6 weeks, and close follow-up.
And with that Lugdunensis patient, you know, it was 1 of 2. We just repeated blood cultures, and you know, I don't think it's going to grow, but if it doesn't grow, you know, we still did an echo. And we're gonna end up giving 2 weeks of cefazolin and then probably 2 weeks of Keflex. Actually, we're gonna do a midline and 2 weeks of IV and 2 weeks of PO. So just to treat it very aggressively, because you can see how scared I am of it, right?
Yes.
Yeah. So let's see, and then a new topic. So I think that was a good review of the important things to know about Staph aureus.
Just to remind you all, get those labs, get those tests, and then treat it as real, even if it's 1 of 2. Diverticulitis happens a lot, and we see in outpatients and inpatients. And if you have diverticulosis, where you have diverticulosis outpouching, about 10 to 15% of the time, those areas of the colon will get infected and inflamed. And you can either have complicated or uncomplicated. Uncomplicated, there's inflammation, but there's nothing else going on. What does complicated means? You have abscesses, fistula, obstruction, feet perforation, sepsis. So that is complicated diverticulitis. There's newer data and new guidelines that are coming out, how we should treat uncomplicated versus complicated. So in the next slide, what the new guidelines say is that, you know, CT is high sensitivity to figure out if there's diverticulitis. Uncomplicated patients with no risk factors for complicated diverticulitis can be managed in outpatient setting in medical supervision if they can drink fluids, have social support, wish to avoid admission. In patients with uncomplicated diverticulitis, no risk factor for complicated diverticulitis, antibiotic treatment does not affect the quality of life or reduce related complications or need for surgery, although it has slightly decreased the likelihood of ongoing diverticulitis. So what they have recently found is that here's who's high risk for who is high risk for progression into complicated. Computer CT scan that shows air, fluid collection, long inflamed colon, elevated inflammatory markers, immunosuppressed patient, recurrent antimicrobial use for similar episodes, sepsis, symptoms for more than 5 days, unstable comorbidity, systemically vomiting. These are all complicated, then you need to treat with antimicrobials. And then what are the most common type of bacteria we see? So most common type of bacteria in diverticulitis is what you find in your colon, right? Basically the colon bacteria is coming out. So Anaerobes are very common.
Mhm.
Gram negatives are very common. So they did a really nice study. This was done in Netherlands. What kind of antibiotics do we need to use? Back in the day, we used to use 14 days, 21 days. So what they found is giving 2 days of Unison and stepping down to finish off with oral augmentin. No more than 10 days was plenty for patients, even and they didn't have any complication follow-up at 6 months. So you could do a shorter course, 10 or less days, and oral augmentin was good in this study. Another study where they looked at 148 patients and they had abscesses about 3 centimeters or so. And again, for this type of patients too, antimicrobials for 10 days plus or minus was enough. And again, follow up at 60 months. There's no major medium follow-up of 60 months. Rate of failure was about 12% in the patients who had abscess. And again, in this patient, treatment greater than 10 days was not associated with treatment failure. So about 10 days of antimicrobials are okay. So studies suggest that there's no need to extend duration of antimicrobial treatment beyond 10 days in non-surgical treated complicated acute diverticulitis. So takeaway is if you need to treat it, 10 days is good. We don't need to go longer than that. Another study, they looked at antibiotics for uncomplicated diverticulitis. So those are the folks with no high risk factor, no abscesses, no perforation. They had about 1,400 patients on both arms. One arm got antibiotic and one arm didn't get antibiotic. And the arm, there was no statistical difference in all-cause mortality, complication, emergency surgery, length of stay, and recurrent diverticulitis. So this meta-analysis found there's no statistical difference in outcomes between patients with acute uncomplicated diverticulitis who were put on observational therapy compared to antimicrobial regimen. I'm not saying we jump to that, but there is data coming out that shorter duration of antimicrobials is okay, and not all patients need antibiotic. Okay, and any questions so far for all of you? We went through a lot of different topics. We have other topics too, but maybe we stop here.
Yeah, I think that's a good idea. I think that's enough information for one day.
Yeah.
I think that's plenty of information. We did include information about C. diff in this presentation, which, I think
we could talk about it next time.
Sure. Yeah, and it's in the presentation. So if you'd like to review it, I think, it's all good information, but yeah, we don't want to run overtime. We want to respect everybody's time.
Yeah.
So any questions about what we've talked about so far?
On meningitis, diverticulitis, Staph aureus bacteremia that we could answer? Are you all getting a lot of meningitis or seeing a lot of meningitis cases recently?
Yeah, it feels like we've been getting a lot lately. Also, diverticulitis. It seems like we've been getting a lot of bowel perfs as well. All right. Well, thank you everybody for joining. If you have any questions or any comments for us or any future topics that you want us to discuss, please send us an email and let us know.
We appreciate everybody. Thank you.
Yes, and we're always available for any questions, for any patient questions. All right. Thank you very much.